Kolia. I'm based in Kimberley, urologist for the state, and I do some private practice where I do treat a lot of patients with erectile dysfunction because there's more options in private practice. In the state, things are very limited.
Great. And I'm Bhavik Shah. I'm a surgeon here in the United States, and I specialize in men's health, sexual health, erectile dysfunction, prosthetic surgery. It's a pleasure to be here with Dr. Kolia, and hopefully we can share some thoughts.
Awesome. Thank you so much. I really want to take this opportunity to thank you for all the good work you've been doing. And as we did meet before, you told me what your links with Africa, so you're always welcome. And thank you for the great work. You know, in the US, I suppose the patients are a bit more clued up and more informed. I know in South Africa, being a developing nation, a lot of our patients don't have very good education, and sometimes that is a problem for us. And so we spend a lot of time trying to just explain things to patients. I've got a few basic questions for you, which I think would help explain to my patients or to our patients basically how to manage and how to treat erectile dysfunction. So just to ask you, is erectile dysfunction an exclusive disease? Is it something you get when you hit a certain age, or does it affect all age groups, all races, and all ethnicities?
Yeah, that's a good question. And just to point out, I will tell you that lack of awareness regarding self-health, men's health in general, is worldwide, right? And I think it's more of a male thing than like a South Africa or American thing. Men don't want to know, and they're very, very bad about seeking out help. They just assume, they'd rather assume that everything is fine than risk knowing that maybe there's something wrong, right? And so men in general, I think it's more of a male thing than like an American versus African thing. So just something worth noting. With respect to your question, erectile dysfunction is equal across all races, right? Not across all genders, obviously, right? So it's a male thing, but across all races, right? And so you'll see erectile dysfunction in America, you'll see it in Africa, you'll see it in Europe, you'll see it in Australia. It is everywhere. What varies is how often people seek out help. And even then, like I said, men in general are not good at seeking out help. If their partners make them seek out help, and maybe in the United States, their partners are more likely to make them seek out help. So if their partners make them seek out help, then they're more likely to show up, usually with their partner holding their hand or telling them, you better sit down, you know, it's that kind of thing. So in general, it is, everybody has it. It's very, very, very common. In fact, a quarter of the entire male population has erectile dysfunction, and that includes young, healthy men, right? And as you get older, that percentage goes up. And it's not that age itself causes erectile dysfunction, is that all the other medical problems that come with age, right? So you're more likely to have diabetes, you're more likely to have heart disease, you're more likely to have high blood pressure. And all of these things are risk factors for erectile dysfunction. So it becomes more and more common as you get older.
Definitely. Yeah, I think that is true. We see back home that unless the partners make them come, they usually take a good few years before they come. And so a lot of times our consultations actually are with couples and not just with the men. All right. And then when we talk about the options for treating erectile dysfunction, and you know, specifically with this group of videos, when would a person consider an implant or a device for the treatment of erectile dysfunction? Where along in the ladder or in the program would you offer your patient that? Would it be right up front, or would it be towards the end, or would it matter on the pathology?
Yeah. So with the erectile dysfunction, we always start everyone off with meds if it's available, right? We always say, look, if you're young, especially if you're younger, right? If you're younger, you want to try as many options as possible. But we always start with medications. You always want to go with the non-invasive route. You don't want to jump to surgery. In fact, we don't even want to do surgery if you don't need it, right? We
Yeah.
only want to offer it if it's your best option, and it usually oftentimes is. The problem is sometimes the medications are either too expensive, not available, or they don't work, right? So if they don't work, then we say, okay, let's reassess. Meds are not an option. What else can we offer? We talk about injections. We talk about vacuums. We talk they're medications that you can put inside the urethra, the channel that you pee out of. We offer those options. The problem with those options is they also come with the risks. They may not work. They may work too well, which means you get an erection that won't go away, and that can put you in the hospital. That can cause scarring.
Exactly.
That can cause pain. They can cause pain with injections. You do have to give yourself a shot in the penis every time you want to have sex, and a lot of patients don't want to do that.
Yeah.
The intraurethral options, like the pellets that go inside the urethra, are very difficult to obtain. They're very expensive, and they cause burning, right? And those can also cause erections that last too long. And then a vacuum erection device probably has the lowest satisfaction rates. And the problem is, even once you get an erection with the cylinder over the penis, when you take that cylinder off, most people lose the erection. So now they're trying to use a ring or something to maintain it. And it poses a challenge. The problem with all these options is it takes trial, error, and figuring out. And when you're in the mood and your partner's in the mood and now you're fumbling around with some of these options, it can be very frustrating, right?
Yeah.
Because you're trying and then the mood's over. And then you're trying and it's not happening and the mood's over. And so for a lot of patients, they say, look, I just want something that'll, when I'm ready and my partner's ready, we can have sex. And that's where the penile implant comes in. And so I always encourage every option. I never talk anyone into surgery, but honestly, the product sells itself, right? It'll tell, it's the only thing that you can do where you can have an erection when you want for as long as you want. The patient satisfaction rates are through the roof. The partner satisfaction rates are through the roof. And the reason is because now you're not fumbling around trying to get an erection, trying to match your erection to the moment. Instead, when you're ready, and that's the wonderful thing about implants.
That's true. A lot of patients have frustrations with the medication not working timeously, and even the injectables. So, personally, I don't like using the injectables. When, as you mentioned, the last you mentioned was the vacuum devices. How important is it to use a vacuum device when you're considering implant surgery? Is there a role for it? Is it a good to have, or is it a must-have?
I'll tell you, most patients don't use a vacuum ahead of time. Most of my patients do use a vacuum ahead of time. And the reason is because the one thing I counsel patients on is, listen, you've lost length. I guarantee it. If you haven't had a good erection in years, you've lost length. Think about it this way. If you see a paraplegic, a patient whose legs don't work, right? You look at their legs, their calves are super thin, right? Their thighs are super thin. And the reason is because they're not getting blood flow and stimulation. They're not using that muscle, and that muscle loses, it atrophies, it loses its thickness and its length, right? The penis is the same way. If you're not getting regular morning erections, and for your penis, those erections are its form of exercise. If you're not getting regular erections, it's going to start shrinking. So now you go in for surgery and you want a penile implant, and we can only put in an implant that will fit. So we'll measure you at the time, and whatever that measurement is, that's what you're going to get. If you want to try to regain that length that you had before, you got to start getting those regular erections again. And a vacuum is a way to do that. You put a cylinder over the penis, you turn it on, you maintain an erection for 5 to 10 minutes every day, just like you would have at night when you had morning erections, right?
Yeah.
By doing that, what you're doing is re-stretching and re-engorging the penis and trying to bring back some of that length. On average, most patients that do it for at least a month will gain back at least a centimeter. And I think that's important.
I'm glad you mentioned that, because I think I just recently introduced it when I'm doing my implants. I never used to do it before. And just on a side note, the most common question I get when we do see patients that request implants is, "Doc, can you make it bigger?" So how do you answer that, Dr. Shah?
Yeah, I mean, so with a penile implant, I make patients take ownership. If you want it bigger, you gotta work for it, right? So number one, you got to use a vacuum erection device. If you don't use a vacuum erection device, you're not allowed to tell me it's you've lost length. So that's deal number one, and I tell them that up front. Okay. Number two, there are surgeries that we sometimes offer, at least I sometimes offer, that does increase penile length and girth. But all of these extra surgeries, they come with risks, right? And so you're increasing the risk of infection, increase the risk of a complication. So you know, it's not that you can't make it bigger, is that making it bigger comes at risk. The safest way to do it is to use a vacuum. You use a vacuum, it's very safe. You do it 5 minutes, 10 minutes every day. It's like going to the gym, except you
Yeah,
don't go to the gym for this one, right? So it's like going to the gym every day. It's an exercise, like working out every day, except you're working out the penis. Do it every day. If you want to do it twice a day, do it twice a day. If you do that, you're going to gain some length. You're going to gain some stretchability, and we measure your penis on stretch. So if you do that, you're making your surgeon's job easy, and we'll be able to put in a bigger implant.
yeah, no, I like that way of looking at it, taking your penis to jump. It's a good way of putting it. Um, so now my patients decided they would like to have an implant. So how they go about preparing themselves for an implant? I mean, a lot of these patients are smokers, alcoholics. They have comorbidities, especially the older ones. How do you prepare your patients for surgery?
Yeah, yeah. So who's a good surgical candidate? I tell patients that are smokers, listen, I want you to quit smoking for at least 4 to 5 weeks before surgery. There's data that shows if you quit smoking for at least 3 weeks, ideally 4 to 5 weeks, you reduce your risk of infection, skin breakdown, right, by almost 50%. So you're already reducing your risk just by quitting smoking. Okay. It
Good.
doesn't mean the next day you start smoking, right? You gotta stay quit at least for that 3 month period if you can afterwards. I'll tell you, most patients do not do that.
Mhm.
Um, but many of them try. And if you're able to, you're going to reduce your risk. If you're not, then you can't complain if you get an infection or skin breakdown afterwards. Again, you got to take ownership of yourself. Another thing is diabetes. You got to get your sugars under control. I check A1Cs not necessarily just to exclude someone, but to see how a patient is doing with their control. If their A1C is 12, they're not going to have surgery. If their A1C was 12, but they work on it and 6 weeks later it's 10, then yeah, maybe you can have surgery. Ideally, I want it under 8, but I use it as a guide. If your A1C was 6, and then I check it right for surgery, and now it's 8, I'm probably going to cancel your surgery because you really are not taking ownership of yourself. So it's really important because after surgery, if you don't take care of yourself during that period, you just take everything for granted. You will get an infection. You will be miserable. It will fall apart. Something will happen, right? So the patients that are irresponsible, and I see that up front, I tell them, look, we're going to delay your surgery until you show me that you care as much as I do for, with your outcomes. And so that's, I do think it's important for patients to understand, listen, it is a surgery. It's a very minor surgery if you do everything right, but it's a surgery. And I want to make sure that you're doing everything in your power to heal well because I want you to do well. And if you're not, then I'm not going to do your surgery for you.
Exactly. No, I mean, it's important. Patients need to take responsibility. And it's far too often it happens that they expect us to be in control of everything.
Yeah,
Um,
exactly.
and now, okay, so in the post surgical space, how do you prepare your patients for the post surgical few days or weeks? What specifically the do's and the don'ts, etc.
Yeah. So this is what I tell patients. Yeah, I'll see you the morning of surgery. We'll talk again about some of these risks. We'll start antibiotics ahead of time. Don't eat or drink
Mm.
after midnight the night before in preparation for surgery. After surgery, um, you won't have much pain. typically because I use a local block that numbs the nerves. And that block tends to last 2 to 3 days. Uh, that does not mean that you can go home and have sex. Okay. You got to go home and heal.
Yeah.
No showering until a drain comes out. You usually have a drain in there. The purpose of the drain is to suck out any little bit of bleeding that's in there so that it doesn't store in the scrotum. There's always a little bit of bleeding. That's the purpose of the drain. You got to maintain that drain. You got to take care of it. You got to empty when it's full. You got to replug it. Then we take the drain out about 2 days ago, 2 days later, and then the day after that, you can go home and you can shower. Okay. Up until then, there'll be no showering, but you want to take a wet washcloth, keep everything clean. Okay. Once you can shower, you want to let water run down your shoulders for the first week and just wash it off. You can dab soap and water, but let water run down your shoulders rather than hitting it directly. After about a week, you can let water hit it directly. No soaking in any kind of water. No soaking in a tub, a jacuzzi, a pool, a beach. All right. No soaking anywhere for 2 months. Light duty, but I want you walking from the first day. I want you up on your feet. You can go upstairs, but one step at a time. No running marathons, no heavy lifting, nothing over 10 pounds for about a month. So light duty, light walking. I want you up on your feet, moving so that gravity and motion and movement will get your bowels working again, will get your blood flowing, and blood flowing helps healing. Icing for the first 3 days. Ice, 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 ice. Okay, 20 minutes on, 20 minutes off. Icing will reduce swelling. It only helps for 3 days. After 3 days, if you can put heat on it, heat helps with healing. If you put heat, again, just like you were icing, 20 minutes on, 20 minutes off, it'll help break down any little bit of blood that's still there in the scrotum. It'll help with the swelling, and it'll help with the healing. After a month, you could do almost anything. Typically around a month, we'll see you. And as long as you've healed up well, you're cleared for sex. If you're diabetic, it may take another week or two to be cleared. So keep that in mind. At about 6 weeks, you can literally do anything except soaking. At 8 weeks, you can do anything you want.
Okay. So thanks for that. That was nice and detailed, and I think the patients will have a good idea of what they have to expect, what they're going to expect post-operatively. And then just quickly, long-term complications. Is this now a once-off thing? If you fix me and till I die, I'm going to be fine, or do I expect a few bumps along the road?
Yeah, bumps can always happen, right? I mean, bumps are what make us who we are. So, I mean, will you have a perfect surgery and a perfect outcome and a perfect longevity? Sure, it's possible. But the lifespan of these implants is about 10 to 15 years. In fact, data shows 88% of patients still have a good first implant at 10 years, right? But will yours break? Probably. Think of this just like a car, right? This is like a Maserati in your garage, right? The more you use it, the more likely it is to break down. And at some point, it will break down. If you take good care of it, it'll last longer. If you do your tune-ups, come to your doctor's visits, make sure everything's good, you're probably going to last a long time. If it breaks, then we replace it, right? Just like if your Maserati breaks down, you're going to replace it, right? So this is no different. You take care of it, it'll probably last, okay? But if it breaks, it's replaceable. And just think of it that way. And what I tell patients is, look, I've seen these things break within a year. I've seen it last 26 years before we have to replace it. Wow. If you use it so much that you break it within a year, well, that's great. More power to you, okay? Then you deserve a replacement because you've earned it. So don't worry about it breaking. If you're so concerned it's going to break that you don't use it, then it's kind of like a Maserati parked in your garage that you never use. It's just kind of sitting there, right? And it's, as much as it's there to look at, it's even more important that it's there for you to use, okay? So just think of it that way.
Yeah, just a side joke there is, why does everyone think of Italian sports cars?
Yeah, you're right. It is like a sports car, though. I mean, the analogies make sense, right?
Yeah, no, it does. It does. And tell me, what about continuing oral medication post-implant? Is there any benefit to it? Do you routinely tell your patients to drink their PDE5s?
After surgery?
Yeah.
Yes. So there is benefit to it. Some patients will get something called SST defect, or they'll get something basically a decrease in engorgement of the head of the penis.
Yeah.
Typically, the way I do my surgery, I try to limit that by decreasing the amount of dilation I do inside the erectile body, trying to preserve some blood flow around the implant. But sometimes you can still get decreased engorgement. And engorgement of the head of the penis when you're aroused is part of the experience of having good erections, right? Even
Yeah.
with an implant. And so using PDE5 inhibitors, it increases the engorgement of the head of the penis. So rarely, I'll tell you, not many patients actually need it or use it, but I do have a handful of patients where their biggest complaint is they just don't have as much engorgement. And I tell them just take this daily, and that way, whenever you actually have sex or you're aroused, you'll get better engorgement, and it works. It works like a charm, and it's a great option.
Okay. Awesome. Thank you so much. I really appreciate this opportunity to speak with you, and and I hope to see you soon. And thank you very much.
Oh no, thank you for having me. I'm looking forward to seeing everyone just in a month or so. It's going
Yeah.
to be fun.
Can't wait.